Being able to focus on root cause and succinctly define them sets the foundation for the remainder of the root cause analysis. Organizations will need to establish guidelines when identifying and documenting specific systems flaws and lead to sentinel events. The five rules of causations capture root causes in their documented analysis. Rule 1, clearly show the cause and effect relation. Incorrect, our resident was fatigued. Correct, our residents are scheduled 80 hours per week, which led to increased levels of fatigue, increasing the likelihood that dosing instructions would be misread. Rule 2, use a specific and accurate descriptor for what occurred rather than negative or fake words. Avoid negative descriptor such as poor, inadequate, wrong, bad, failed, careless. Incorrect, the manual is poorly written. Correct, the pump's user's manual had a point phone and no illustrations. As a result, nursing staff rarely used it, increasing the likelihood that the pump would be programmed incorrectly. Rule 3, human errors must have a preceding cause. Incorrect. The resident selected the wrong dose, which led to the patient being overdoses. Correct. Drugs in the computerized physician ordering entry CPOE system are presented to the user without sufficient space between the different doses on the screen. Increase the likelihood that the wrong dose could be selected, which led to the patient being overdoses. Rule 4, violations of procedure are not root causes, but must have a preceding cause. Incorrect. The techniques did not follow the procedure for CT scans, which led to the patient receiving an air bolus from an empty syringe, resulting in a fatal air embolism. Correct. Noise and confusion in the prep area, coupled with production pressures, increased the likelihood that steps in the CT scan protocol would be missed, resulting in the injection of an air embolism from using an empty syringe. Rule 5, failure to act is only causal when there is a pre-existing duty to act. Incorrect. The nurse did not check for stat orders every half hour, which led to a delay in the start of an anticoagulation therapy, increasing the likelihood of a blood clot. Correct. The absence of an assignment of designated registered nurse to check orders at specified times increased the likelihood that stat orders would be missed or delayed, which led to a delay in therapy. The most important step in the root cause analysis process is the identification and implementation of actions to eliminate and control system hazards or vulnerability that have been identified in the contributing factor statements. Therefore, review teams should strive to identify actions that prevent the event from reoccur, or if that is not possible, reduce the severity or consequences if it should occur. Using tools such as action hierarchy will assist teams in identifying stronger actions that provide effective and sustained system improvement. Teams should identify at least one stronger or intermediate strength action for each root cause analysis review. In some cases, it may be necessary to recommend actions classified as weaker actions in an action hierarchy as temporary measures until stronger actions can be implemented. It should be understood that weaker actions such as training and policy changes are often necessary to establish proficiency and expectations, but when used alone are unlikely to be sufficient to provide sustained patient safety involvement. Stronger actions, less tasks require less reliance on humans to remember to perform the task correctly. Architectural physical plant changes replace revolving doors at the main patient entrance into the building with powered sliding or swinging doors to reduce patient falls. New devices with usability testing perform heuristic tests of our patient blood glucose meters and test trips and select the most appropriate for the patient population being served. Engineering control forcing function eliminate the use of universal adapters and peripheral devices for medical equipment and use tubing fittings that can be connected only the correct way. For example, IV tubing and connectors that cannot physically be connected to sequential compression devices or SCDs. Simplify process, remove unnecessary steps in a process. Standardize on equipment or process. Standardize on the make and the model of medication pumps used throughout the institution. Use barcoding for medication administration. Tangible involvement by leadership. Participate in unit patient safety evaluations and interact with staff, support the root cause analysis process, purchase needed equipment, ensure staffing and workload are balanced. Intermediate actions, redundancy, used to register nurse to independently calculate higher rate medication doses. Increase in staffing, decrease in workload. Make float staff available to assist when a workload peak during the day. Software enhancement, modification, use computer alerts for drug interactions. Eliminate reduced distractions. Provide quiet rooms for programming PCA pumps. Remove distraction for nurses when programming medication pumps. Education using simulation-based training with periodic transfer sections and observations. Conduct patient handoffs in a simulation lab environment with after-action critics and debriefing. Checklist cognitive aids. Use pre-induction and pre-incision checklists in operating rooms. Use a checklist when replacing flexible fiber optic endoscopies. Eliminate look and sound alike. Do not store look-alike next to one another in the unit medication room. Standardized communication tools. Use readback for all critical lab values. Use readback and repeated back for all verbal medication orders. Use a standardized patient handoff format. Enhanced documentation, communication, highlight medication name and dose on IV bags. Weaker actions. These actions require more reliance on humans to remember to perform the task correctly. Double checks. One person calculates dose, another person review their calculation. Warnings. Add audible teams or causation labels. New procedure, memorandum, policy. Remember to check IV sets for hours. Training demonstrate correct usage of hard-to-use medical equipment. It is recommended that the glucose analysis program be reviewed annually by senior leadership and the glucose of effectiveness and the continued improvement. The following measures may be useful. Percent of contributing factors are written to meet the 5 rules of causation. Prevent of glucose analysis reviews with at least one stronger or immediate strength action. Percent of actions that are classified as stronger or immediate strengthened. Percent of actions that implemented on time. Percent of actions are completed. Audits or other checks that independently verify that has a mitigation has been sustained over me. Staff and patient satisfaction with the glucose analysis review process. Survey response to HRQ survey questions pertinent to the glucose analysis review process. Process of glucose analysis revised present to the board. Now we play 80 minutes veteran affair glucose analysis video. You will more realize how to practice glucose analysis.
Good morning, everybody. Thanks, first of all, for working on this team. You have a folder in front of you with all the information and the details, so let's quickly go over that. We had a patient come into the ER. There appeared to be multiple areas of weaknesses that could have easily led to this patient losing their life. Luckily, that didn't happen, but we want to avoid a situation like this in the future. The purpose of our team is to identify the areas of weakness in our facility's process so that we can recommend corrective actions to prevent further mishaps and potential patient injuries. We understand that each of you are very busy with patients, but this is an important part of improving the care that we give to veterans. Remember, patient safety and the RCA process are VHA directives. Carrie, please give us a quick summary of what transpired.
Okay. An 82-year-old male was admitted from nursing home through emergency room with chief complaint of weakness and a history of 200 milliliters coffee ground emesis 2 hours prior. Gastric lavage in ER changed from coffee grounds to clear. Blood pressure 117/60, decreased to 90/60, but restored with IV fluids. His temperature was 97 degrees, pulse 90 beats per minute and regular, hematocrit 30%, and white blood cell count of 17,000. GI medicine consultation was requested. The patient was scheduled for upper GI endoscopy and sent directly to the endoscopy suite from the ER that afternoon. Upper GI endoscopy revealed stomach filled with clots. Active bleeding from duodenal ulcer was revealed after clots were removed, and bleeding controlled with cauterization. Recommended treatment plan: ICU for observation, blood transfusion, and HCT every 6 hours, and IV protonics. This plan was discussed with admitting medical resident that signed off to on-call resident at 5:30 p.m. The ICU was full that evening, and after discussion between residents, the patient was admitted to 4 North, a general medicine unit. That time was 6 p.m. At 11:30 p.m., the nurse found the patient to be in respiratory distress, hypotensive, and bradycardic. A stat page was made for the on-call provider. The on-call medical resident arrived quickly at the bedside. This was the first time she had seen this patient. It was a busy night with 7 admissions. After quickly reviewing the chart, she ordered a 2-unit stat blood transfusion and asked for the most recent HCT, which was 19%. The nurse had not seen this report. She had 12 patients that night. The blood bank reported back to the nursing unit that this patient had not had a type and cross match ordered upon admission, and that no blood was available for this patient. The patient deteriorated rapidly and went into cardiac arrest. CPR was initiated and the patient was resuscitated. It was then that the patient was placed in ICU.
Thanks, Carrie. So we have 45 calendar days to complete the RCA process. So let's try and schedule all of our meetings today. If you're unable to meet this commitment, please speak up now. Leadership has selected you and is committed to removing barriers so that your participation is possible.
Count me in. I want to ensure something like this does not happen to another veteran.
Great. We certainly need your perspective on this case.
Look, I realize this is important, but as chief resident, though, I have a lot of responsibilities. Clinic, morning report, administrative duties. I'm constantly putting out brush fires, all right, if you know what I mean. I'm not sure I can do it.
Okay, Anthony, I'm going to make sure that everybody in the department knows that you have this duty as a priority for the next 6 weeks. Your colleagues will simply have to cover you for some of your other responsibilities. The team needs your input on this case.
I'm happy to be here, and we'll do whatever I can to help this process.
Great. For the remainder of the meeting today, we will review the case and discuss the rules of conduct for an RCA. Remember, we're here to solve systems issues. Therefore, please concentrate on the process and not the individual. We may disagree, but let's keep our interactions professional and respectful.
Are we legally protected in these meetings?
The answer is yes. A federal law, 38 U.S.C. 5705, protects all discussions, documents, and work products in an RCA from discovery, subpoena, or evidentiary use in any legal proceeding. We're also bound by the same law not to disclose what happens here related to the RCA process, and any information collected through our investigative processes. So please do not share any details of the RCA with anyone outside of this team.
Well, what happens if in the course of our work we find staff in gross violation of policy, procedures, or standard of care? I mean, don't we have a responsibility to the VA and our patients to turn them in and seek disciplinary action?
Well, in the instance that we identify the adverse act as a criminal act, an intentionally unsafe act, an act related to substance abuse by a provider or staff for suspected patient abuse, we will stop the proceedings and refer to facility leadership for action. These situations are outside the scope of the RCA process.
Well, if that's the case, we still cannot divulge what we've discovered up to the point of stopping the RCA, is that right?
That's correct. Our findings at that point are sealed. We cannot disclose anything learned in the RCA process to the administration. They would have to conduct their own separate investigation. So, if there's no other questions, let's start by creating the initial flow diagram. Well, it looks like everything checks out in the ER.
Well, it says here there was an issue with a blood bank. Could we go take a look?
Sure.
And how are orders received at the blood bank? Perhaps we should interview a technician on staff that night?
Yeah, that's a great idea. I'll add that to the list.
Well, we've identified the person at the blood bank on duty that night. So, we might also consider checking out the ICU as well.
Okay, that's a good idea. Let's do that. What time do you have on that?
I have 6:30 p.m. So according to the report, the ICU was full that day. There was nothing that could have been done.
I don't know. Could have just been a miscommunication.
I agree. Let's go talk to the ICU nurse.
Okay.
We're starting to understand what happened. What don't we know?
We don't know whether or not blood was sent for a type and cross-matched from the ER.
What about the discussion between the GI medicine consultant and admitting medical resident? Since the GI note recommended a blood transfusion, can we assume that that was discussed?
We can't assume anything we don't have evidence for.
Okay, what was the discussion between the ICU team and the on-call medical team like that night? Who made the decision to admit the patient to general medical floor?
Yeah, and it seems to me that that staff nurse did not know how sick this patient was. She had too many sick patients to take care for that night. The beds were full. We were short-staffed. This patient should not have been on that unit.
Hold on a minute. Let's hold judgments until we have more information. At this point, you're all raising important questions. In the time we have remaining today, let's decide where we will look for answers.
For starters, we should talk with the admitting resident and the ER nurse who cared for the patient.
Well, do we have a hospital policy about sending blood for type and cross-match for GI bleeders?
I would hope so. How could a patient be admitted to our hospital with a diagnosis of GI bleeding without having blood set up for him? Do we have clinical guidelines for this kind of thing? This is a huge screw-up.
Hold on. Remember that we're focused on systems here and not looking for someone to blame, okay? So let's decide where to look for answers. All kinds of resources here.
So we've identified the following for interviews: the ER staff nurse, the admitting medical resident, the GI medicine consultant, the ICU medical resident, and the 4 North staff nurse. Are we missing anybody?
Yes, the blood bank tech.
Oh, yeah, good idea.
Thanks. Before the next meeting, please review documentation so we may begin the analysis.
Well, and what about the interviews?
Good point. Remember, these interviews can be intimidating, and we're not conducting an interrogation. We're simply trying to find the flaws in the system so that we can try to avoid similar situations in the future.
Makes sense to me.
Yeah.
Good morning, Tom. You know John Santos?
Dr. Robinson, we know you're very busy.
I'm happy to be here today, but I do have a lot of patients waiting. How long will this take?
This won't take too much of your time. We just want to be sure to get your perspective of what happened. So, as you know, this is a root cause analysis where our focus is on systems, not people. Our goal is to try and understand what happened in order to fix our systems of care.
Okay, but what if people are at fault in this case? How can you ignore that?
We're not trying to find someone to blame. If we discover professional misconduct in the course of our analysis, we'll refer that to the administration. The confidentiality of the RCA is protected under federal law. None of our work in this RCA could ever be used against any member of our staff in an administrative punitive action.
Okay, understood.
So, would you tell us your story from the beginning, dealing with this patient in this case?
Sure. I was called by Dr. Carol Samples to see an elderly patient who had arrived in our ER that afternoon with a history of coffee emesis that day. He was a little hypotensive, but responded readily to IV fluids. I believe his hematocrit was in the low 30s. So I told Carol, Dr. Samples, that I was finishing up my clinic and I would scope the patient later that afternoon.
What was the result of the endoscopy?
It was a large ulcer that began bleeding after I cleared the clot away. Cauterized the ulcer and successfully controlled the bleeding. After repeated saline irrigations, I was comfortable that there was no further bleeding.
What did you do at that point?
I called Dr. Samples and we discussed my findings and recommendations.
What were your recommendations?
Well, this was an elderly patient with a large ulcer and an acute bleed. I thought the risk for rebleeding in the subsequent 24-hour period was high. So I advised that the patient be transfused 2 units of blood and observed in the ICU overnight. I also recommended that he be on IV protonics for gastric acid control.
Then what happened?
Well, later that evening, I was walking through the ICU and noticed that the patient was not in the unit. I was surprised because not all the beds were full. I asked the ICU resident about this, and she indicated the patient had been sent to 4 North.
4 North?
Well, our policy in the Department of Medicine is to allow the residents to make the clinical decisions and write the orders. I had made my recommendations to the admitting resident regarding the care of the patient.
I see. Do you have anything to add?
Yes. I was shocked to learn the next day that the patient had almost passed and had never had any blood set up for transfusion. We were very fortunate that he was able to be resuscitated.
Definitely.
Carol, I trust you know Dr. Washington.
Yes. Good morning, Anthony.
Good morning, Carol. First of all, let me extend our appreciation for your willingness to help us understand this unfortunate event. This is a root cause analysis, which means everything we say in this process is confidential and protected by federal law. Okay, also nothing said in this room can affect your condition of employment at this hospital or in the residency program.
Okay. I'll be happy when this is over. It's a little unnerving.
I understand. So can you give us a picture about what happened the day and night of this patient's admission? We're interested in your story about what happened as you remember it.
Well, I was called to the emergency room at about 4 p.m. to see a patient from a nursing home.
Okay.
And when the blood bank got back, there wasn't any blood left, and I didn't know what to expect.
So you didn't learn what happened to your patient until the morning report the following day?
I felt awful. I didn't know that it wasn't checked, and the fact that I could have lost that patient, it was terrifying. And then during the meeting, I just left because I thought I'd get cut from the residency program.
Mm-hmm. I'm so sorry to hear that, and we understand how it must have been a terrible feeling for you just to think that your fellow residents were pointing fingers at you.
Yeah.
It's okay. It's okay.
It was definitely a low point.
Carol, we're here to learn what happened in order to prevent this from happening again. Okay, we're not here to blame you or anyone. We see this as representing a serious vulnerability in our systems of care. Okay, this could happen to anyone on call that night. Okay, we have no doubts about your abilities and commitment to patient care.
Thanks.
And before you go, Dr. Samples, do you have any thoughts about what we can do to prevent a similar case from happening again?
Well, I've thought about this a lot. Mm-hmm. First of all, I think I should be more, organized mm-hmm. and have things well thought out before moving on to the next patient and double checking my records. Mm-hmm. Systems-wise, we could prompt up a computer so that way we can type out all the information so that way nothing gets missed in the future mm-hmm. for us.
Yeah.
So maybe we could do some standardized order.
Yeah.
Mm-hmm. And we could do that when a patient GI...
When they have that diagnosis of
mm-hmm.
GI bleeding, right?
Admitted.
Yes.
Mm-hmm.
That's good.
Yeah, see? These are really good suggestions. This is helpful to us.
Thanks. I hope you guys come up with some really good solutions. Mm-hmm. I wouldn't want any of my colleagues to experience anything that I've gone through in this case.
And just know that your feedback is so helpful to us. We appreciate you coming here.
And rest assured, we will do our best.
Okay, so what have we learned from our findings?
Well, the admitting medical resident failed to follow through with the recommendation of transfusing her patient before she left for the day. And there seems to be some miscommunication about the availability of beds in the ICU.
Right. Initially, there were no beds available in the ICU, but Dr. Robinson said that there were. Then the order for blood type and match was not communicated to the blood bank, so the blood bank did not have the proper blood available for the patient. And then finally, the resident and nurses were responsible for too many patients as a result of understaffing.
Okay, folks, we've done enough research and analysis. Let's complete the final understanding. So what do we think? Any ideas, any answers?
Well, I mean, it seems like a perfect storm to me, but we could start by taking the forcing function and moving it up in the hierarchy.
Yeah, I think that makes sense.
Right there, yeah.
Now we can start on developing our recommended actions. Let's review what constitutes a strong action. Strong action steps are permanent rather than temporary, physical changes rather than procedural changes, and invoke human factors principles. In this case, a strong action step might be to establish a standardized electronic handoff reporting mechanism from the physician leaving the hospital at the end of the workday to the on-call physician for that night.
Sure. You know, one thing I've had in mind is that all patients admitted with a diagnosis of GI bleeding should have a forcing function in their electronic medical record to automatically include a type and cross match for 2 units of blood in the admitting orders.
Yeah, that's good. You know, that's definitely a systems fix.
Now that we have the final understanding and some good actions, we can work on outcome measures. Okay, we've got some great recommendations. The next step is to present this to our director. He will review and either concur with our actions or not. If he does not concur, we may need to reconvene and make some additional suggestions for corrective actions. Once we've gained the director's concurrence, we will provide feedback to the person that reported this event so that they realize that they are part of improving patient safety throughout the VHA. I believe this report will help to avoid future incidents like this from happening and improve our system of care as a whole. Thank you for your time in this RCA process.
The key to establishing successful root cause analysis and action process lies in leadership support. The components of a successful programming include establishing transparent risk-based methodology for triggering events, selecting the correct personnel to service on the team, providing a team with the resources at a time to complete the review, identifying at least one stronger or intermediate strength action in each review and measuring the actions to assess if they are effective in mitigating the risk, using tools such as risk-based prioritization metrics, triggering questions, the 5 rules of causation, and the action hierarchy will aid the team in identifying and communication cultural factors and taking actions that will improve patient care and safety. Okay, thank you for your listening. Wish you have a good time. See you next time.